Hi, I'm Dr. Angela Yakey.
And I'm Dr. Kathleen O'Neill Smith.
Welcome back to the FIRRIMup Doctors, Good Medicine docuseries.
We are so glad you joined us.
We want to provide you with credible health resources, guide you in your treatment options, and fire you up to take control of your health.
Hello, everyone, and welcome.
Hi.
I'm Dr. Kathleen O'Neill Smith, and here is Dr. Angela Yakey. Happy October. How are you, Dr. Yakey?
Hi, everybody. Yeah, so we're so glad that you've joined us again. This is a really fun series, and we're really spinning the A story on all this and focusing on how you can be well on multiple levels.
I am so excited. I love that we're going to have our friends as guests that are going to share their information and knowledge with all of you.
Yeah, so next slide. For this week, we have Dr. Anna Cabeca, and then next week, Dr. Kathleen and I will be reviewing a paper from 2018 from the New England Journal of Medicine that talked about the relationship between oral contraceptive medications and breast cancer. And then the last Thursday, we're going to do a COVID update as promised, but we're going to do a spin on it. We're going to bring over our regenerative medicine scientist friend, Dr. Ian White, who's going to review a paper that looks at cells, stem cells, and something called, and different types of signaling molecules that can help potentially with COVID.
Yeah, so they're medicinal. These are all medicinal. And please tell your friends, come, because he is a wonderful teacher. He really knows how to simplify concepts. So I think you're going to really, really enjoy Dr. White.
And yeah, just for this crowd to know, there have been trials already on using stem cells to treat especially the lung phase of COVID-19.
But just to be clear, Dr. White doesn't really use stem cells. He uses other non-cellular, acellular signaling treatments that are medicinal, that act as medicines, but aren't stem cells. So just so that we're really clear. But he has studied stem cells at Harvard, Dartmouth, and Cornell. So you'll love him.
Yeah, and he actually was the lead paper on the American Heart Association with his work actually with stem cells in the heart on a basic science level. So he knows the field really quite well, and I think you'll enjoy his comments. Next slide. So without further ado, I want to introduce our friend and colleague, Dr. Anna Cabeca. I met Dr. Cabeca teaching at Age Management Medicine Group over a decade ago now, and she's become a great friend and colleague to both of us. And actually, she is an Emory-trained, triple board certified OBGYN doctor, best-selling author of Hormone Fix, Many Weeks, Many Weeks on Amazon bestseller list, and now Keto Green 16. I consider her a pioneer in women's health. And so who better than to have a conversation with on postmenopausal hormone replacement therapy and breast cancer than with Dr. Anna Cabeca. Hi, Anna.
Hello. It is great to be here with you brilliant ladies.
Hello, Anna. We are so lucky to have you.
Well, I'm excited. I'm excited to be here. This is an important topic. And, you know, like I sent this article to Angela. I saw this editorial. It popped up in my research. I was interviewed on Fox about breast cancer and mammograms, like how frequent do we need to be doing mammograms? And of course, there's controversy with the American College of Radiology, the American College of Physicians, the American Cancer Society, the American College of Radiology, no surprise, wants us to do like, you know, annual mammograms, very much more frequent mammograms than the American College of Physicians recommends, as well as the European Cancer Society recommends, as far as, you know, frequency of when do we mammogram, when don't we mammogram. The issue is that, of course, you know, visits to the doctor and including a mammogram, considering a screening mammogram, they've dropped significantly. The statistics that I was given was 95%. I'm like, wow, that's pretty significant. So I was digging into the research and I saw this article, an editorial published July 28, 2020 in the Journal of the American Medical Association. First of all, that's my birthday.
Oh my goodness.
I was not reading it back then. That was cool. And so I remember the date. That's why. Not that I can usually cite dates or scripture, but here we go. But it should have made front page news. I mean, this continued reanalysis or a continuation of analysis of the Women's Health Initiative trial should have made front page news. So I'm like, Angeli, look at this.
Yeah, so I thought, seeing how this is Breast Cancer Month, and we had pulled the paper and looked at it, I thought it'd be good to discuss. So I'll just lay kind of the baseline with the Women's Health Initiative. And actually, Dr. Kathleen trained at one of the major centers, the Brigham and Women's Center. And I, at the time, was at medical school at the University of Florida, which happened to be one of the centers as well. So the WHI was a huge study funded by the government primarily to understand the relationship between hormone replacement therapy and outcomes. And at the time, I remember, because I was preparing for my boards, basically, if you did not have a contraindication to hormone replacement therapy, the right answer for a menopausal woman was to put them on hormones. Unfortunately, at the time, the standard was something called Premarin, or CEE, abbreviated here, conjugated equine estrogen, Premarin, pregnant horse's urine. That is not the kind of estrogen that we knew in our body. And also a synthetic progestin called medroxyprogesterone acetate, MPA. So we have to stop here, girls, right? Because this is not what we are currently prescribing. We're currently prescribing bioidentical hormone replacement therapy. And this study looked at what was standard back then. It was called Premarin if it was just the estrogen, or Prem Pro, which was a combination horse estrogen and synthetic progestin. Any comments on that, by the way?
Exactly right. And I think that's why it was so interesting, as also the confusion in the medical literature. What is progesterone versus the progestins, the synthetic progestins?
Yeah, and it's still confused all the way. I looked at this because I presented on bioidentical progesterone in 2013 and 2014, and really the literature even to this day is confused. So don't get confused. Ask your doctor if you're on hormone replacement therapy, if you're on bioidentical progesterone as opposed to synthetic progestin. And you'll understand the concern after we review this data. So basically, they enrolled almost over 27,000 postmenopausal women between 1993 and 1998. And it turns out the average age was 62 to 63, and that's important in just a minute.
Yeah.
And so when you looked at the combined arm, the Prem Pro arm, horse estrogen plus synthetic progestin, it was stopped prematurely for safety in 2002. And I remember, because I was doing primary care in my office and my phone was ringing off the hook. I think you guys had the same experience.
Absolutely. Yeah.
Because this one did hit the press. And it hit the press because it was stopped prematurely for safety after 5.6 years, because what they found was increased risk of heart attacks, thromboembolic disease, which is clot in the lung and clot in the legs, and breast cancer. On the other hand, it showed a decreased risk of colon cancer and hip fracture. Subsequent to that, we're going to analyze what happened in the early post-intervention phase, meaning after they stopped it, they continue to follow them, and later. But for now, I just want to say that combined synthetic horse estrogen and synthetic progestin had increased heart attacks, clots, and breast cancer, decreased colon cancer, and hip fracture.
So specifically Premarin Pro, Premarin or Prem Pro. So that's
Prem Pro for that one.
Mm-hmm.
Okay. On the other hand, there was another arm with hysterectomized woman that just had Premarin, pregnant horse's urine. Okay. And that was stopped for safety 2004 after 7.2 years. And so there were two arms, noting that both arms actually had great dropout. The dropout on Prem Pro was upwards of 50%, and the dropout on just Premarin was 54%. So there was some controversy about the dropout as well. But when you analyze the data, going back to the Prem Pro that stopped in 2002, it turns out those women's the average age was 62 to 63. And so that's why, in looking back at that, we were thinking the increased risk of heart disease and thromboembolic disease, well, primarily heart disease, because they had pre-existing plaque or junk in the arteries that got unstable when you added estrogen. So that's why now, for example, flash forward, there's something called an estrogen window where we want to start estrogen early in the perimenopausal, menopausal transition.
Well, and I think too, what's really important to say, okay, well, why was there the estrogen only arm to begin with, right? Because like back in, what was it, early 1950s when Premarin came out, estrogen, it was just Premarin that was used, whether you had a uterus or did not have a uterus, we gave you Premarin. And the purple pill, right? You know, like mommy's little helper, these types of nicknames that it got, right? And, but what happened was women had an increased risk of endometrial cancer. And so this increased risk of endometrial cancer was due to unopposed estrogen because there was no bioidentical progesterone to oppose the estrogen, and the lining of the uterus thickened. So that came up, okay, we need to discover something that we can use to, you know, oppose that estrogen in the endometrium. And that's how progestin, Provera, was originally developed to oppose the unopposed estrogen. So to oppose that estrogen. And both of these forms are oral. Transdermal Premarin did not come about till much later, but oral, by oral route. So oral estrogen and oral progestin, oral conjugated estrogens, and oral progestin, Provera, not bioidentical progesterone, not at all, synthetic and patentable, and held that patent with exception for numbers of years, right? So we have that that combination. So what did we start seeing when women started taking the Provera? We could see more headaches, more issue, you know, other significant issues and side effects with the addition of Provera. So it was only given to women with a uterus. And I think that in and of itself is pretty fascinating. And it wasn't until, you know, more recently with Dr. Fournier's E3N study that looked at progesterone and different types of progestins to really look at the safety of different progestins. And then one other note on this initial results of the Women Health Initiative study is, I mean, like the scientists knew that oral estrogens have an increase in, you know, inflammatory markers. So inflammatory marker like our CRP, C-reactive protein. And that we know the route of administration also increases that risk of thromboembolic disease and inflammatory markers. So that's a really important understanding in the interpretation of these results.
So I want to just say a couple of things for clarity. One of the things that Dr. Akey and Dr. Cabeca are talking about is there's a yin and yang. You need estrogen, you need progesterone. I was a 9th grade biology teacher, so I'm going back a little bit here. But estrogen and progesterone help you in a normal menstrual cycle to be healthy and to be prepared to have a baby. The estrogen thickens the uterine lining, which is why uterine endometrial cancer can be caused when you just use estrogen alone in people who have a uterus. And you need the progesterone and the withdrawal of the progesterone later in the month of menses in order for that tissue to be shed. If that tissue remains there, those cells, in my mind, this is not scientific because I try to make things less scientific so you understand, go rogue. And when those cells go rogue based on your genetics and other things, there are other components, but we'll keep it simple, then you can, you know, if you have a propensity for this, you can end up with a cancer. But I think estrogen and progesterone generally work together, yin and yang, and really help to keep the body balanced. One other thing that's really important is that we're talking about postmenopausal women. And in this particular initiative, the WHI, we're talking about people 10 and potentially 15 years after they went through perimenopause. And the point that Dr. Akey made is that the sooner you start and maintain, you know, some level of healthy hormone, non-synthetic, healthy bioidentical hormone, the better we believe you are, just like we're healthier when we're 20 and 30s and 40s, as opposed to without any hormone at 50, 60, 70 and beyond.
I love the way Dr. Kathleen makes it so easy to understand. Thank you for that. So just out of curiosity, you were training at the Brigham when when it hit the press in 2002, and the Brigham and Women's Hospital, which is a Harvard hospital, actually was the center of the WHI. How did it ripple down I'm just curious. I never had this conversation with you to your practice.
A great question.
Joanne Manson was at the Brigham at that point, and she was kind of one of the primary investigators for this study. And I think she was crushed. This is not what she expected to happen here. I think she was really crushed. And there was a lot of, dramatic response to this, because I remember even in my clinic not wanting to prescribe, just for whatever reason, Prem Pro, and getting a lot of pushback on that earlier, prior to these results coming out, and then feeling so relieved that I hadn't been prescribing it all along at the Brigham. But at any rate, I just didn't. I didn't know anything. I just didn't feel comfortable for some reason. And so ultimately, I think what happened, and my take on this is that it became like, okay, how can we salvage this work? And they started to do all this data dredging, and they continue to do it, Dr. Cabeca. You know better than anybody that the data dredging from this group of people, because it's such a large cohort, 28,000 people, that they just continue to data dredge. And I really don't think that you can do that with studies. You have to have you can look for relationships, but I think that we really learned that there are many ways. I don't know. I found it disturbing, the whole thing, to be honest with you.
Well, that would bring us up in terms of the data dredging or long-term outcome to this article that we were talking about that got published on Dr. Anna Cabeca's birthday this year, July 28th, by Dr. Jablonski. So going down to the last bullet point on this slide, if we look at Premarin, or horse estrogen only, which is kind of antique thinking to just give estrogen without progesterone to women, but we'll put that aside for now. But the thinking then was, if you've had a hysterectomy, then you just get plain estrogen.
Well, let's emphasize that, because Dr. Icky, because when the whole concept was we only need progesterone for the uterus. And this we know so well now, and you've lectured on this, we need progesterone for the brain, the bones, the fascia, right? For collagen. So healthy memory, good night's sleep, all of these quality of life factors are important addition of progesterone, right?
That's a huge point, because there are many doctors who still don't believe that if you've had a hysterectomy that you need at least bioidentical progesterone, but you have progesterone receptors everywhere in the body, but especially in the brain. And my lecture was always about neuroactive steroids and preserving brain health with progesterone. So yes, that's a great.
Let alone the fact that even total health, DHEA and other hormones are made from progesterone. So if we have extra, there's a pathway in which progesterone is utilized. So it's really, really important. You get the point. Everybody gets the point, I'm sure.
So on this call, if you've had a hysterectomy, you should be asking your doctors for both of those hormones, estrogen and progesterone, not just estrogen, if you think you need hormone replacement therapy.
And a bioidentical at EP, estrogen, progesterone.
Bioidentical and known to the body. Mm-hmm. But let's go ahead and look at what the data dredging revealed and got published in the Journal of the American Medical Association. So Dr. Jablonski, who was actually the author of this paper as well this summer, published in 2015, that last bullet point, found that horse estrogen alone was associated with lower breast cancer risk. That's interesting. In the early post-interventional phase, meaning the drug phase, as well as late post-interventional phase. And actually it was lower breast cancer risk through intervention in early post-interventional phase, but it was not seen later in the later part of the interventional phase. The paper that got published this summer showed there were 10,739 women in the estrogen alone trial. Compared to placebo, it was actually associated with significant lower breast cancer incidence. So what ended up, Jablonski showed that in the early postmenopausal phase, and now in July of this year, published in the late postmenopausal post-interventional phase, that there was decreased breast cancer risk. And that's what was huge. And that's what Dr. Cabeca was saying should have hit the front pages.
It should have hit the front pages. It's such good information. It's like, okay, well, you can be confident because we're all, what is in the news? Anti-estrogen, estrogen is bad for you. Like let's, do extreme anti-estrogen therapies, right? But in fact, it's even this exogenous equine, over 30 different types of estrogens didn't show any increased risk. And this is oral estrogen in and of itself. So that whole concept of, we know oral estrogens, like I don't put anyone over 50 on oral estrogens. We switch by certainly if they have any risk of cardiovascular disease even earlier, but definitely 50, 55, they're switched to transdermal estrogens, vaginal estrogens, sometimes troches if we're in a low risk group. So I think we can use that safely, but we want to avoid the oral route to avoid the hepatic metabolism and the inflammatory consequences. So it's it's really interesting to look at this result and say, okay, well, even this, not my first choice in hormone replacement therapy at all, showed a lower, not no significant increased risk, but a significantly decreased risk of breast cancer. And that whole concept of better quality of life, lower morbidity and all-cause mortality. And I think that's awesome. That's fabulous.
And should you have had breast cancer in the estrogen-only arm, there was a significantly lower breast cancer mortality than if you had not had estrogen.
Right.
It's really important. I would say in Boston still, obviously I'm here, and I would say any of the doctors that are associated with the Harvard hospitals, particularly the Brigham and the BI, they are still so frightened 20 years later to ever use an estrogen. And if I ever use bioidentical estrogen and progesterone, they scare the patients literally so frightened, come running to my office, afraid to take it, etc. So I think two things that are really important to think about is, one, I know that there is I don't know if you met Dr. Nachtigal when we were in New York last year, Dr. Cabeca, but Dr. Nachtigal is an 80-plus-year-old, much older clinician who's still working. She's a GYN, Lila Nachtigal, and she is at Columbia, and she believes so much in hormonal replacement for brain health, for all health, as you said earlier, and estrogen use perimenopausally. And we'll tell every woman that they should take estrogens right away. But that's one of the few conventional docs who I personally know that will promote it. What about I think one of the things that happen with estrogen use is, can we talk a little bit about that MRI versus the mammogram and what we can expect with estrogen use if it's done properly in terms of fibrocystic or anything found in the breast on exam?
Yeah, I think this is an interesting area because we think that excess estrogen or estrogen dominant was associated with increased breast density, increased breast tissue density. And so that makes it harder to interpret our current mammograms. And so I think that's something that, we need to consider. But we have better ways to image the breast, right? I mean, that's the bottom line. We're using this, nothing's changed in mammogram and mammography in so long. Although I did go get my mammogram today for the first time in a couple of years. And I was happy that it wasn't the metal, the slab stainless steel, ice cold metal plate that I last used, but much more gentle procedure this round with this rad tech, which was great. But yet still thinking, oh my gosh, this is still an archaic way to image the breast. We do have better ways to image the breast, and including MRI, including looking at it from different ways with thermography and ultrasound. And these are things that should interpose our routine mammogram follow-up. We should be looking at the breast in other ways, just like we look at hormones, not just in the blood, we look at it in other ways as well. We should be looking at the breast in other ways. So I think a big thing about this estrogen and this study is that we can say that estrogen's safe. Stop villainizing estrogen, right? It's misogynistic, this anti-estrogen talk. I really do feel like it's anti-feminine. And it is working. It really does scare women. And we need estrogen, and not just, like you said, not just for our, healthy breast and healthy bones and brain, and to have an improved quality of life, but also for brain, definitely for memory, for brain health. And we're looking at this as, like I talk about in my book, Keto Green 16, as an important factor for fuel for the brain, because glucose utilization in the brain is estrogen dependent. And when we're deficient in it, our brain's actually starving. And so hence another critical reason to go to ketones, but also, a supportive level of estrogen. I think when it comes to estrogen replacement too, we're not just looking at, we don't want the estrogen levels that we've had in our 20s. We want supportive levels of estrogen. And what we can know from the studies, a little bit goes a long way. Mm-hmm. And, even looking at this conjugated equine estrogen at 0.625, 30 different estrogens in there being metabolized by the liver, that the actual percentage of good, safe estrogen is really, really quite low to convey a benefit. And I think that's really reassuring too.
Very reassuring. I totally agree with you. Logically, the way I think about it is, if you think about, starting at age, we'll call it 12, from 12 until 48, let's pick, that's the childbearing age. That's when we're at our healthiest. And that's when our estrogen levels, our own personal estrogen levels, are most optimized. Same for men with respect to testosterone and the prostate and the PSA. And it's so interesting to me that we villainize these hormones, because they are what allow us to be healthy. And the incidence of heart disease, the incidence of thromboembolic disease, the incidence of a brain disease or memory issues is like as low as it gets when we're at our optimal level of hormones. So why do we villainize these hormones when, as they go down and as we get to zero in complete deficiency, that's when we end up with the diseases that are increasing for men and for women. So it's very logical to think we need some of this. We need a supplemental supportive amount of this in order to keep our brains healthy, our bones healthy, et cetera. So it's just fascinating to me that it really has to do with, what we have available that we can prescribe, right? Or not. So, and there may be some, male, female gender component too, as well, of what we push, but it's really interesting. Thank you so much for that clarification.
Yeah, and I love that too. And it also goes back to, again, the importance of progesterone, a male and a female hormone that both decline with our age, and for women 35 to 45, we get this rapid decline in progesterone, and how it's been villainized to recommend progesterone, but synthetic progestins of the adverse derivatives, like we know that with progesterone, there's progestins or progestogens that are either pregnane or pregnane type of different derivatives, and some are more dangerous than others, like Provera, for instance, the medroxyprogesterone acetate, again, not bioidentical progesterone. And they're in our birth control pills. They're affecting our youth who are taking this daily, yet that's like pushed out without second thought. And we know that has negative effects. And we can see from this study, the Women's Health Initiative study, how dangerous these progestins are. And when we have a bioidentical alternative that's safer, a safer progesterone to use in hormone replacement therapy, perimenopause through postmenopause, this, I'm shouting it, woo, everyone listen, this is important. This is why I find so passionate about using progesterone and pregnenolone higher up to help support clients through this transition phase. I take it daily.
And you brought up a very good punchline, that the synthetic progestin, for example, MPA, medroxyprogesterone acetate, in the fourth bullet point down, showed that line, the Prempro showed increased risk of breast cancer. And then we know that from the OCP data, oral contraceptive data in younger women, at 5 years, there's increased risk of breast cancer. So we really think it's a synthetic progestin that increases breast cancer. But the problem, again, in the literature, it's still confused. They don't differentiate synthetic progestins from bioidentical progesterone, which is key take-home point for this crowd today, is to think bioidentical progesterone. For the brain, the other thing is that I always teach that estrogen is an antidepressant. So I say estrogen is God's Prozac to women. And then progesterone is God's Valium to women. It calms us down. And so appropriate levels and the appropriate balance is critical for optimal women mentation as well as women's health. And finally, this crowd knows the book that we just, I co-edited, and Dr. O'Neill Smith and I need to get you a copy of this, Dr. Cabeca. We actually published a chapter, Hormonal Effects on Fascia and Soft Tissue in Women. And we went through, the bottom line is that all that connective tissue that keeps us upright, keeps us from getting wrinkly, keeps our pelvic floor from dropping so our vaginas don't fall out down below, it all has hormone receptors. So there's multiple reasons why that we need hormones, including aging and structure, brain, heart. You heard it all.
Oh, Dr. Akey, you say that so well. I'd have to double up my doses today.
It's true. It's wonderful.
Yeah, no, it's so true, because like all of a sudden, like say a woman will say, hey, Dr. Anna, I'm having pain when I get up in the morning. I'm, having pain walking. I'm not as limber as I used to be. And then lo and behold, you put them on your regimen, right? If you're doing, for me, it's like, okay, we're going to detox, get keto green, get on some Mighty Maca. Let's use some bioidentical progesterone. If you're still cycling, let's do this. And let me tell you, improvements overnight. Oh yeah, we're going to throw in some Julva in there too, some topical DHEA for sure for the pelvic floor. We don't want anything falling out. No. So, I mean, these are things that make a huge difference, these quality of life factors that can make a really important difference and to help people through this transition time of perimenopause and beyond, because our risks continue to increase and worsening with gynecologic issues like prolapse, right? Incontinence, dryness, and pain, discomfort. But that concept of hormonal content in fascia, I mean, that's groundbreaking. And that's so critically important to let people know about that, because that's, that's part of our quality of life.
And yeah, thanks for bringing up the Julva cream. In my own clinical practice, and I know Dr. Kathleen as well, our patients do really well with topical Julva cream. I remember when I was helping you with the clinical trials on that in my office, we were trying to come up with a name, and I like juicy vulva, Julva. But I think in the end, I think you ended up coming up with joyful vulva, Julva. Yeah. But I'm telling you, I have so many testimonials of my women where they had incontinence that got better, or painful sex. They hadn't had great intercourse in years with it because it hurt. And that topical DHEA cream or over-the-counter Julva that you developed worked really, really well.
Well, and I think this brings up a really important point too. Thank you. Thank you so much, Dr. Akey, for that. And always for being part of the for that initial clinical phase too. You're a first responder. What do you call it? Rapid adapter. You're just so smart. I love that about you. Good clinically. I would say too, one of the things that just brings up is the question of when are you too old to begin hormone replacement therapy? I think that's something we should address. Kathleen, do you want to?
Well, I think, for me, it depends on, I always ask people, what is their goal for hormone replacement therapy? People have different issues. If it's the brain, if it's the bone, if it's, whatever, and how long have we gone out? But how long have we been since the menopausal period? But I do think that if you were to talk to certainly Dr. Nightingale, and I love at least that she's extremely conventional in my mind. I love her dearly, but she's very conventional. And no matter what, depending upon the brain, the bone, and whatever else you're treating, whether it's the vulva, the vagina, or anything else, we can consider hormonal replacement. I mean, you have to think about what you're treating. I don't know that you can get it all back if you start 10 or 15 years later, and you've got to be very cautious, and you've got to understand your heart disease risk at that point if you start 10 years late, or your risk for other general diseases, because all of those diseases increase after you're estrogen deficient and progesterone deficient. That's when they begin to go up. So where are we in that curve is the way I think about it, right? So I'm thinking, where is this person? What do they need to have? And then we calculate the risk together, and it has to be the patient's comfort and decision about what they're going to do. And generally I do transdermal. In someone younger, I would certainly do vaginal and other things, but it depends. I never do oral. I would never but there are people, I have patients that come to my practice that are on Prem Pro, believe it or not, from doctors in Boston. And I actually just tell them we can't talk about it. I can't be involved. It has to be out of the realm of what I do. So
Wow.
what do you guys do with people who haven't been able to start right away?
Yeah, I think for me, it's that same thing. I start top down. So I'll start with a transdermal progesterone and pregnenolone. So usually starting progesterone, pregnenolone, let's use it at night, take 1 to 2 nights off a week, and let's get a good night's sleep. And with uterus, without uterus, clients who have been on even unopposed estrogen, they come in and say, Dr. Anna, I feel like a cloud has lifted. I feel so much better. It's a combination of progesterone, neuroprotective effects on the brain, and a good night's sleep. I don't know. But that's what they said over and over again. It made me go, how, that's one of those things. Well, it's not just about our uterus. It's not just about a good night's sleep. There's so much more to it. And so I feel really safe based on the literature to use, to not have an age limit in the right client, to use a transdermal progesterone and pregnenolone. And the second thing is DHEA. So Julva, bottom up, right? I always say clitoris to anus, your prime real estate. You've got that healthy because it's the thing that affects us as we get older the most, and it's really problematic. And we're over 75% of us, right, as we get older, are struggling with issues of the pelvic floor if we're not using preventive methods, if we're not doing pelvic floor exercises, exercising regularly, and hormonal and optional hormonal therapies, or something like Julva. And so we can use these things to really help. And again, transdermal, very, very safe. And what's really nice is the breast cancer literature is saying that even intravaginal DHEA in the studies with progesterone in breast cancer patients is very, very safe, as well as at vaginal, estrogen, vaginal bioidentical estrogen has been very, very safe, decreasing morbidity and mortality in breast cancer patients. So here we have something else that we can do for patients as well. And I think those are important things to consider. And I would say that I've had clients in their 80s and 1 or 2 in their 90s that were on hormone therapy.
Yeah, I have kind of a funny anecdote. I've been managing a woman for like 10 years on bioidentical hormones in the early transition, 40s to now she's like just turned 60, but she had a mom who is demented in Texas, moved her to Gainesville, and I'm like, no, she's like 80, late 70s, almost 80, I'm not giving her hormones. Well, she didn't want to get out of the house. So my patient took it upon herself to give her hormones. And this was about 6 years ago now. And lo and behold, her depression went away. She wanted to go out with the kids, and she just woke up even before all those studies on brain health and hormones that hit the lay press with Dr. Bredesen. So anyway, she had a great quality of life because after that, I ended up started treating her hormones. Unfortunately, she just died last week, but she was already over 90. But that taught me right away that there not necessarily is an age limit. If they're older and I'm worried about heart disease, I'll check out their heart first before starting hormones, and generally have lower levels like this lady.
So maybe it is all about the uterus and the vagina. I don't know. I mean, it's so expensive. Maybe it is. We don't know. What a great session. Let's see if we have any questions.
Yeah, there's 2 questions. And first of all, I do want to say about Dr. Anna's point that her over-the-counter PPR cream is fabulous. I've used it for years. It's progesterone with pregnenolone cream. It's over-the-counter, works really well for sleep, especially in the estrogen-dominant early perimenopausal transition woman that doesn't need a whole lot else. Sometimes I'll use it with a plant-based called chasteberry to act like progesterone. There was a question on Facebook that wondered about Diendyl methane. And is that okay to use? And when do you use Diendyl methane?
Mm-hmm.
I think that is great to use. I think it's, a couple of formulas that I like to use have it combined in with some other estrogen detoxifiers. But I think that Diendyl methane is really a good supportive supplement, especially if there's been fibrocystic breast cyst, breast disease, familial history of a breast cancer, abnormal mammogram. But one thing you would say is, like with any supplement, you need to say, okay, do I really need this? How's my, you know, my environmental interaction with my genetics going? So looking at something, what do we call that? Epigenetics? I was looking for the word. Epigenetics. And so, you know, looking at estrogen detoxification pathway. So how's your estrogen detoxification pathway? Maybe you need it, maybe you don't. And I think that's worth looking at.
No, I totally agree with you. I love DIM. For the right person, it will be a good addition. So you can ask your doctor about that, but DIM is wonderful.
And then there was a question about male health, but I said we have to save it for another session. it's women's health and breast cancer, but we'd be happy to talk about male health. We'll put it on the agenda later. Yeah, so that, go ahead.
This whole thing of moodiness, male or female, progesterone in the evening, like I've used 5-10 milligrams transdermal progesterone in men for good night's sleep, anxiety, moodiness, again, protective, you know, as a protective level. So, but yeah, definitely Absolutely. Love this topic on male health. And don't forget that men get breast cancer too. So looking at testosterone conversion to estrogen and their pathways, especially if they're on testosterone, is so important.
Okay, so we will plan, Peggy, on doing male health session, maybe not Breast Cancer Awareness Month, but we'll do it sometime on our new series on pursuing wellness. So thank you both for joining us. I would like to summarize some important bullet points for the community. If you're going to use if you're going to get hormone replacement therapy, try to use it early in the early perimenopausal transition. There is no reason, in my opinion, to use oral estrogens if you could use transdermal estrogens, because a great point Dr. Cabeca made was that when you take estrogen orally, it goes through the liver. It can cause increased clotting and increased inflammation. Third point is that if you've had a hysterectomy, there are still some conventional doctors who say, hey, you don't need any progesterone. Well, we argue that there are progesterone receptors on every cell in the body, but especially the brain, the fascia, that you should get progesterone balanced hormones. The fourth point is that please remember that, that hormones are multi-system. It affects soft tissue, brain, heart, sexual health, perineum down below, as we talked about, and that we do believe that optimal health is optimal hormones. So we so appreciate you joining us. There was one other question about troches. Troches bypass the liver as opposed similar to transdermal. It doesn't go through the liver. So we do like troches for hormone replacement therapy.
Similar to doing it intravaginally because it's similar tissue. The mouth is similar to the vagina, believe it or not.
Yeah, so she said you could use it intravaginally. You could use hormones intravaginally. We just want to avoid the oral route with estrogens. However, if we have a patient who doesn't sleep, we like bioidentical oral progesterone because it gets broken down to a metabolite, a chemical that helps you sleep called allopregnenolone. So to be clear, estrogens you want to use topically in the vagina or under the tongue. With progesterone, if you're not sleeping, you want to use it orally. Otherwise, you could use that great product that Dr. Cabeca has, PPR cream topically. Do you two agree with that?
Yeah, just so with that concept of troches, I love troches because they're convenient and you could go from, you know, using it transbuccally between the cheek and gum or under the tongue or intravaginally. And now it is true that when we are doing it this way, some is ingested and swallowed. So it's definitely a preferred way for me, you know, for my life at this time. So one thing I monitor as I monitor with my patients is inflammatory markers. So things like your HSCRP and looking to see, as long as that stays nice and low and you're doing everything like to decrease risk of coagulopathy as well, like healthy omega-3s, a keto green diet, low inflammatory diet, these things can make a difference. So when we're using a troche, we have to consider that some can be orally absorbed as well. And so let's just check those boxes.
Well said. What a great honor you joined us, Dr. Anna Cabeca, best-selling author of Hormone Fix.
Love being here with you ladies. Thank you. Oh my God.
I'm with my two best amicas, so I'm really happy. So for everyone else, Dr. Kathleen, enjoy the rest of your day. Emily, thanks for helping us. For everybody who's been following us, thank you. And please share this very, very important webinar with your friends and family. We so appreciate you. And for now, be safe, be well, and God bless you all. Bye-bye.
Right. I wish Dr. Anna were here every day.
Ah,
I love her.
I loved it. I loved it. That was so good. I'm going to share it on my Instagram too.
Wonderful.
Just this last little summary segment, which was so good.
She's the best. She's the best. Thank you.
Yeah, thank you guys. Really well done.
Bye, everybody. Thank you.
Sometime.
Okay.
Okay.
Thank you.
Bye-bye.
Bye.
So a special thank you to our FIRRIMup doctors and Dr. Anna for joining us today. Now is time for some supplement deals. So if you would like to stay along and listen, then now is the time. Just like last week, we have Dr. Anna's, some of her products on sale on our FIRRIMup Get Healthy store. We have the Julva cream that they were talking about in today's webinar, the Keto Green Shakes, the Keto pH urine test strips, Mighty Maca, and then the Pura Balance PPR cream. These are all available on a 10% discount using the code FIRRIMup Dr. Anna. And that is going to get you 10% off on our store. Next, we have vitamin D, which we also showed last week. We have the Micellized D3 and K2, and then we have the D3 tablets, both in 2000 IU and 5000 IU. Again, the same thing as last week. It's going to be on our Get Healthy store, and FIRRIMup Vite D is the code. And lastly, a new thing we're doing is the Kick COVID-19 to the Curb Fall Flu Season IV Special. And this is going to be a series of 4 IVs, and you will also receive a paperback copy of our KCC guidebook. If you're interested in this at all, it's a great deal and a great time to do it. You can just email us at firrimupdoctors@gmail.com, and someone will get back to you with how to get that all set up. And then speaking of our Kick COVID-19 to the Curb guidebook, we always have a few more on sale, as well as always on our ebooks, either on Amazon Kindle, Google Play, or Barnes & Noble. Again, if you buy one of these guidebooks, whether it's paperback or ebook, you can take 20% off of Ultra Potent Vitamin C and Zinc AG. Just have to show proof of receipt, which can either be online, a screenshot, or a piece of paper. And lastly, we have Dr. Akey and Dr. Kathleen's Fascia Function and Medical Applications textbook. It is available now. We have a few paperback copies available at the NFIM office. And if you would like a paperback to pick it up, you can email us at nfimgmv@gmail.com. It'll be $55 and it'll be curbside pickup, so it'll be contactless. Someone will come bring it out to you. If you don't want to go in person though and would rather order it online, you can get it off of our website, firrimupdoctors.com or amazon.com. And lastly, if you would like to get a discount, you can use the code SCI20 to take 20% off of the book, but that is only available to be used on our FIRRIMup Doctors website. Unfortunately, Amazon will not accept that coupon code. But of course, if you have any questions or concerns, you can always email us at firrimupdoctors@gmail.com, our NFIM hotline, which is shown here, nfimgmv@gmail.com, or you can call us and we will be more than happy to help you in any way possible. And I want to thank you all for sticking around and joining us today. We really hope you're liking our new series, and next week we'll be back on some more topics on breast cancer. So everyone have a wonderful Thursday and a great weekend.
We're so glad you joined us today.
We hope we've given you the tools to take control of your health.
For more good medicine and information about any treatments, supplements, and resources discussed today, please visit us at www.firrimupdoctors.com. That's FIRRIM updoctors.com.
And wherever you're listening from, remember to like us on Facebook and subscribe to our YouTube and podcast channels so you don't miss out. The information provided is not a substitute for professional medical advice. This should not be used to diagnose, treat, or manage health problems without consultation. If you do experience any of the symptoms discussed today, please contact your nearest healthcare professional.